One of the difficulties that we face in providing advice to patients relates to advising those who are asymptomatic and therefore fit within the framework of the NHMRC guidelines versus those who present with active symptoms. I'd now like to present a series of case studies which highlight these differences and how we can apply this framework on a day-to-day basis in a clinical setting. In case study 1, we present a 58-year-old woman who attends her general practitioner to discuss mammography and cervical screening. In addition to her stated goals, as part of her regular workup, the following should be included: a systems review, including GI symptoms, assessment of her family history of bowel and other cancers, inquiry about whether or not she's already participating in the National Bowel Cancer Screening Program. If this woman is asymptomatic and has a negative family history, then she should be advised to participate in the national program when next invited, and preferably to commence biennial screening outside of the program now. It's important to note that if not already participating, it's likely that she won't be invited for up to 2 years from now when she turns 60, and really should be tested in the interim. Personally, I would refer her to a private FOB provider in the interim to prevent a 2-year delay in her being screened. Let's just say that this woman tells you that she's already undergone colonoscopy 4 years ago and that the result was normal. She indicated that she was going to be invited for a repeat scope in another year from now. Under these circumstances, there's really no formal indication for her to have a repeat scope, and she should be educated regarding the national guidelines and the option of FOB testing. It's important that she makes an informed decision regarding the options of either continuing colonoscopic screening, including discussion of the risk of 1 in 1,500 of colonoscopic perforation and its consequences, including the potential for surgery and a stoma, versus the option of FOB testing. There's also the added inconvenience with colonoscopy of bowel preparation and perhaps 2 days off work. In this setting, I would offer her immediate self-funded FOB testing, and she can then participate in the national program when it's offered to her at her next birthday at 60 if she wishes. It's worth highlighting here that in 2015, the program has not yet been fully rolled out to offer biennial FOB testing, so it's entirely reasonable for Australians to screen with FOB testing outside the program in the interim. Importantly, this woman should be reassessed at future consultations to ensure that she's commenced screening for bowel cancer along the lines suggested, and that she understands the importance of biennial FOB testing and vigilance for interval symptoms, as well as guidance regarding primary prevention. In case study 2, we present the story of a 35-year-old man who presents to his doctor requesting a referral for colonoscopy, as his grandfather has just been diagnosed with bowel cancer at the age of 79. The young man has no symptoms and is otherwise well, and no other relatives have been affected. This is a common scenario where we see young relatives of an older affected patient referred requesting immediate investigation. In this particular circumstance, urgent investigation is not required. This young man fulfills the criteria for level 1 risk under the NHMRC guidelines, and the guidelines are clear in suggesting that he does not require screening until he turns 50, as his family history does not currently significantly affect his personal risk of bowel cancer. Having said that, there'll often be pressure to take action in this setting, so there are a number of options to offer this patient. The guidelines would suggest that he requires screening either at age 50 or 10 years younger than the youngest affected relative. And as his grandfather was over 55 at diagnosis, colonoscopy is not indicated, but rather FOB testing. The recommendation relating to the age of diagnosis of the affected relative is perhaps the most contentious aspect of the guidelines, and many patients simply refuse to accept this recommendation. This is not difficult to understand, of course, as the experience of seeing a relative suffer from advanced colorectal cancer is distressing regardless of their age, and likely to evoke an emotive response from the patient's family. Under these circumstances, there are a number of options that can be offered. Firstly, the young man should be educated regarding the current status of the guidelines and that he should be commencing FOB testing at age 50, and he should be educated about vigilance for interval symptoms and primary prevention. If he does feel the need to act now, then it's very reasonable to offer him the option of commencing FOB testing now outside of the National Bowel Cancer Screening Program. A kit can then be purchased online from the Cancer Council Victoria website, from some pharmacies or from other third-party providers. All GPs should be familiar with these options. When he turns 50, he can then again discuss the role of colonoscopy versus FOB testing, and of course, whatever options may be available in 14 years' time when that deadline arrives. For the time being, however, I would counsel him against upfront colonoscopy, as in this setting, the likely very low yield is probably outweighed by the risk of perforation associated with the scope itself, days off work, and potential out-of-pocket costs. FOB testing alone should provide him with adequate reassurance if he wishes. In case 3, we present a 55-year-old woman who presents to a general practitioner with 3 weeks of bright rectal bleeding. It's important to identify up front that this patient is symptomatic and hence not eligible for the national program, which applies to asymptomatic patients. Her family history is negative. Systems review was unremarkable, with no symptoms of proximal pathology, specifically no change in bowel habit, weight loss, abdominal pain, and the blood has always been bright. She's never undergone colonoscopy. She was recently sent the national program kit in the mail and has ignored it for 5 months, but now wants to know if she should do the test. In this setting, of course, there's no real value in her undertaking the test at this point in time. She's reported macroscopic bleeding and does not need this confirmed with an FOB test. In this setting, there are a number of options, but importantly, this patient is currently symptomatic and not eligible for screening. If her bleeding is minor, resolving, and she does not need surgical treatment of her hemorrhoids, then I would encourage her to undergo a one-off colonoscopy. In this setting, she's bleeding and over the age of 50, and even though the yield is likely to be low, the risk of the scope is almost certainly outweighed by its benefit. If her scope is normal, then there is no indication for her to repeat her colonoscopy in the future unless her family history changes, or she develops recurrent symptoms, or returns a positive FOB test. I would then advise her to undergo regular FOB testing after the scope and reassess her compliance at each subsequent visit. If she has ongoing bleeding that's worrying her, then it's also reasonable in this setting to undertake conservative management of her hemorrhoids for about 4 to 6 weeks, with fibre bulking and avoiding straining, and then to reassess. At that point, I would recommend colonoscopy, and if her symptoms have not settled, then she could undergo surgical treatment of her hemorrhoids at the time of the scope. If she refuses a scope and has not bled after the original consult, then it may be reasonable to advise FOB testing at that time, but ensuring that colonoscopy occurs should the follow-up test in 4 to 6 weeks be positive. In case 4, we present a 48-year-old male who presents with rectal bleeding for a short period of time. He has no symptoms of proximal pathology, specifically no change in bowel habit, unexplained abdominal pain, or weight loss, and his family history is negative for colorectal cancer. The bleeding sounds to be hemorrhoidal in nature and is associated with straining at stool, but rectal examination and proctoscopy in the office reveal innocuous, small hemorrhoids only. In summary, this man is symptomatic, so again, he's not eligible for the national program. On assessing him clinically, it sounds very much as though the bleeding is perianal in origin. However, in any adult with rectal bleeding, the option of further investigation should be considered, discussed with the patient, and that discussion documented. In this particular circumstance, I'd be inclined to offer him, as he's currently bleeding, 4 to 6 weeks of fibre bulking to see if the bleeding can be symptomatically resolved. And I would organise an FBE and iron studies at the first consultation with instructions to the patient to check the results with me 48 hours afterwards. Assuming that the bloods are okay and that he has a reasonable symptomatic response to the fibre bulking at review consultation, even though this is sounding more and more like bleeding of perianal origin, I would, however, discuss with him the option of investigating with colonoscopy, carefully outlining the risks and benefits of this, including discussion of the 1 in 1,500 risk of perforation associated with the colonoscopy and its consequences. At that stage, the patient will either opt for colonoscopy or otherwise. If they opt for colonoscopy, I'd facilitate that for them. If they don't opt for colonoscopy, I would ensure that I have clearly documented the discussion and the option of the scope being offered. In addition, I'd then suggest to the patient the alternative option of performing an FOB test at that time, just to ensure that there's no evidence of ongoing bleeding at a microscopic level. Obviously, if the FOB test was positive, then a colonoscopy would be mandated. If the patient has not responded to Metamucil after 4 to 6 weeks of fibre bulking, then that patient definitely should be encouraged to undergo further investigation and the option of rubber band ligation of hemorrhoids at the time of the scope. Regardless of the outcome here, whilst the patient, after completion of their treatment, is still too young to be considered for the national program, it would be reasonable to offer them the option of ongoing fecal occult blood testing, self-funded, if they wish. Case 5 involves a 42-year-old male presenting for discussion regarding screening options on the basis of his mother having been diagnosed with bowel cancer at the age of 47. The male patient is currently asymptomatic and has no other major comorbidities. It's important to note that under the NHMRC clinical guidelines, this patient fulfills Category 2 level risk, and hence fecal occult blood testing is not appropriate for him. This patient should be referred for 5-yearly colonoscopy, commencing at an age 10 years younger than the youngest affected relative, should be warned about the importance of ongoing surveillance, and should, as with all patients, be educated about primary prevention. Case 6 is a 54-year-old woman who presents for advice regarding colonoscopic screening. She's asymptomatic, but her family history is significant. Her mother developed uterine cancer at the age of 35 and subsequently died from the disease. Her maternal uncle developed bowel cancer at the age of 42, and his own son developed a small bowel tumour at the age of 54. The patient herself underwent a colonoscopy for low-level symptoms about 5 years ago. Under these circumstances, this woman fulfills Category 3 level risk. Her family history is suggestive of the possibility of an underlying autosomal dominant syndrome, such as Lynch syndrome or HNPCC, as more than 3 relatives on the same side of the family have been diagnosed with HNPCC-associated malignancies at an early age. Under these circumstances, this woman requires not just colonoscopy, but referral to a family cancer centre for formal assessment and counselling of her family. She may well require genetic testing and/or specialised gynecological surveillance. Case 7 is a 65-year-old woman who's received notification from the national program that she's eligible for FOB testing and has been sent a kit and instructions. This woman has no symptoms that she can attribute to her bowel, has had no family members affected by bowel cancer, and her husband has previously thrown out his kit when it was sent to him. Later that year, during a routine consultation with her local doctor for an unrelated matter, she mentions to her that she's received and ignored the kit. Her GP has significant interest in preventative medicine and screening and has thorough knowledge of the national program. She takes a clinical history and determines that the patient fulfills NHMRC Category 1 and hence is appropriate for inclusion in the National Bowel Cancer Screening Program. She spends time educating this woman about her lifetime risk of bowel cancer and the evidence supporting her participating in the program. In particular, she emphasises that her risk of bowel cancer is considerably higher than her risk of cervical cancer. Armed with this information, the patient then promptly completes the FOB test, which is positive. At follow-up colonoscopy, she's identified as having a 2.5 centimetre sessile lesion in her sigmoid colon. This lesion is removed by a colorectal surgeon using endoscopic mucosal resection at the time of her colonoscopy as a day case. Histopathology indicates that this was an adenomatous polyp with moderate dysplasia. At subsequent follow-up with her GP, she indicates to the patient that she now has a significant personal family history of adenoma and she should consider repeat colonoscopy in the future as guided by the NHMRC guidelines. The patient is booked for a recall colonoscopy in 3 years. In addition, her GP educates her about the importance of her family history and suggests the importance of her first-degree relatives undertaking screening. As it transpires, as a result of this advice, the patient's brother obtains an FOB kit from his GP. The result was positive, and he was harbouring an asymptomatic stage 2 carcinoma of the right colon.